Hello friends, this is a case of large 24 centimeter posterior wall myoma in a young unmarried girl. So, we are putting supraumbilical port, that is approximately 10 centimeter above the umbilicus. Here this myoma is pushing the uterus anteriorly and it is reaching up to umbilicus. So, that is why supraumbilical port is essential. So, we are using here preset pressure of the insufflator at 15 and waiting for actual pressure to reach to the preset pressure. So, in this case we will use infrared ureteric catheter also, because myoma was pressing both the ureter and there is a bilateral hydronephrosis of the patient. So, the varus needle is introduced. Now, the pneumoperitoneum is complete. We will extend the incision and we will put the optical port supraumbilical. We will perform this surgery by the 3 port. Optical port is supraumbilical and 2 ipsilateral port will be introduced on the left side to perform this surgery. Now, after doing initial diagnostic laparoscopy, these are the 2 ipsilateral port. These 2 port will be 5 mm. Now, patient head is going down. We will put a steep Trendelenburg position, that is 30° head down, and we can see this large uterus. This is all fibroid what you are seeing. And uterus is pushed anteriorly. On the top you can see that is uterus. So, it is posterior wall, but mostly subserous. This is the uterus, round ligament, fallopian tube you can see on the both the side. Fibroid is completely engulfing the entire pelvis. There is no space either side, because it was taking the ureter as well and pressing it, and there are adhesion with the bowel on the posterior wall of the fibroid. It is adhered with the rectum. So, we will put the infrared ureteric catheter. So, now this is cystoscopy and this is the right ureter. So, guide was introduced and we are using a Striker U kit, that is illuminated ureteric stent. Up to 15 centimeter it will be introduced. So, right side is done. Now, we will do the left side ureteric catheterization. So, either side of catheterization is complete. After that, we will inject the vasopressin at the junction of the uterus, posterior wall and the fibroid, so that transient ischemia will form, and it will also do the hydrodissection. Now, you can see bleeding is started and blanching also started. Approximately 100 ml diluted saline with the vasopressin we have injected, and the dilution is 5 international unit in 20 ml saline. And now, incision will start it with the harmonic. Now, this is the myoma screw which is giving cranial traction, and slowly fibroid will be detached from the surrounding serous and posterior wall. This is the ligation just to prevent the bleeding. At some of the places of the margin of the incision, we will apply ligation, and uterus is pushed up and fibroid is by the myoma screw is cranially pulled. Myoma screw has to be relocated. So that traction can be optimized. Incision is further enlarged, keeping in mind the size of the fibroid. then myomere screw is relocated. These are the posterior leaf of the broad ligament, and this posterior wall is extending on the either side of the broad ligament also. This fibroid is too big to, and it is completely engulfing the entire cul-de-sac and either side of the broad ligament. Now, laterally we can see the ureter that is passing through the serosa of the fibroid, because it is just taking the entire posterior leaf of the broad ligament, and if it would not have been the lighted ureteric stent, then it was difficult to see the ureter in those cases. So, you can see this is the left ureter which is going through the subserous part of the fibroid. So, we have to safely separate the fibroid from the serosa, and this is the extending the incision with the ligature to the right side. Once you have a plane, then ligature you can introduce through the subserous layer and you can extend the incision. This is the ureter which is going touching the fibroid, and thanks to lighted ureteric stent that it is showing that we have to be careful and should not be injured. So, ureter has gone now more lateral and it is separated from the fibroid. Myanmar will be further relocated and further blunt dissection will be carried out to separate the fibroid. We have to be also careful that it should not avulge the uterine vein which go posterior to the ureter near the uterus. Artery go anterior to ureter and vein goes posterior, so we have to be careful. Now, this is the right side. We can see right side, it is ureter is away, because right side of ureter generally crosses the external iliac vessel. So, it is more lateral. Left side of ureter crosses the common iliac vessel. So, it was more medial. So, size is approximately 24 centimeter of this fibroid. So, it is almost covering the entire pelvis and either side touching the pelvic wall and taking the posterior leaf of the broad ligament as extension. Now, further dissection again will be started from the left side. We have to protect the ovary and tube also carefully, because this is a unmarried girl. So, you can see ureter of the right side is giving the transmitted light, and that has to be also carefully kept away. Left and right both the ureter you can see it is in this area, but fibroid is almost out, and serosa which was attached with the rectum and all, we have kept it as it is attached. So, it is separated. Now, we will lift the uterus and do little suction of the collected blood, and this serosa will be kept back to, this is posterior leaf of the broad ligament which is detached from the lateral wall. We will put back to the original place, and we have to suture it. Below is the rectum, and this is the ureteric part on the lateral aspect, you can see on the right and left side. So, we will push back all these serosal lining back in the position. Then we will suture it. So, here we will use the intracorporeal suturing with the Dundee jamming knot, continuous suturing and Aberdeen termination. There is no bleeding, all is dry, and this suturing will be performed. So, this is Dundee jamming knot which has a pre-formed loop. You can go through the loop and pull it out, and it will get locked automatically. we are using only 3 port. So, you have to lift the uterus as well as support the serous layer yourself, because there is no 4th port, and because patient was unmarried. So, we are not using any uterine manipulator as well also to lift the uterus. We can see the right ureter is nearby, but we are carefree because lighted ureteric stent will not allow the right ureter to be injured. Now, we will terminate it. We can check the posterior wall, it is now all covered with the serosa, and then we will terminate the suture by the Aberdeen termination. So, going through the loop, and then you have to pull the nun needle end, and that will lock the suture. After that, again you can bring loop within loop and again pull the nun needle end, and then finally we can go through the loop and take the needle out. So, this is Aberdeen termination. So, entire serosa was closed by the Dundee jabbing knot, continuous suturing and Aberdeen termination. Little suction is done and uterus and cul-de-sac was re-examined, and there is no bleeding. After that suture will be cut. Ovaries are fine, tube you can see fimbrial end of the tube left side, and ovary all is fine. Both the ureter is okay. Below is the rectum. Here is the little, this is a complete fibroid. This is a large 24 centimeter fibroid which was engaging the entire pelvis. This is the left tube, left ovary, that is fine. Fimbrial end of the tube you can see okay, right, and right tube, right ovary and right ureter, that is the left tube, left ovary, and fimbrial end of the left tube, and this is left ovary and ureter is below. So, now we will remove the suture and then morcellation will start. So, we are using here a Storz morcellator. Because of the size of the fibroid, we cannot do contained morcellation, because morsafe endo bag has a maximum limit of 12 centimeter fibroid. More than that you cannot put in the morsafe endo bag, that will not allow. So, and patient is very young, so you do not need contained morcellation. Morcellation will be time taking procedure. So, we will not show you the complete morcellation, and then of course, after the morcellation completed we have to do the port closure. So, morcellation will continue at least for half an hour time. So, we are finishing the video. Thank you very much for watching this video.